Hi, Elizabeth. Hi, Nee.
Hi.
Can you guys hear me okay?
Yeah, very well. Thank you.
Oh, good, good. Can you see my... Can you... Hi, Liz. All right, looks like we're getting everybody on here, so that's great. You guys feel free to... I'll just wait a few more minutes here because it looks like we had 9 people signed in to be part of this, so we have a few more to be jumping on here. So this is my first class like this with Zoom, so bear with me. I'll try to make this work well.
Okay.
All righty.
Have you guys attended, have any of you attended the hormones class before?
No.
Okay.
No.
I haven't.
So, huge topic, right? I mean, we could spend an hour on melatonin alone. But we'll try to focus on most of the sex hormones tonight. And I'll bring up some other things, or if someone has some specific interest, we can certainly, focus on those areas. And, there's some contentious areas out there. However, the evidence is mounting for more and more use of the bioidentical hormones, and the data just keeps getting better. So it's very encouraging. I mean, of course, that correlates with so many great health outcomes. So we'll just going to give this just a touch more time. We're almost there. Let's see. About just a couple more minutes, and then we'll get started. For you guys that are on, do you want, do you have a specific interest in terms of a topic of a hormone that you want me to cover a little more in depth tonight?
The testosterone and DHEA.
Yeah, perfect. Perfect. Couple of these people. Sometimes people have a little harder time logging on, so well, let's just get started. If they want to chime in, they can, and they'll just have to pick up where we're at. So we'll honor everyone's time. But so hormones and BHRT, so that stands for bioidentical replacement therapy. Some people could just call it augmented therapy. Some people call it replacement therapy. And, I'll just start off by saying this, and am I shouting into this, or is this okay for you guys?
No, you're fine with me.
Okay, good. What I tell people is I see more hormone deficiencies when I work in the ER than I do in my clinic. And so I know that might sound strange in the acute care world, but when you think about this, I see more bones broken in the ER, more osteoporotic fractures. I see more dementia. I see more heart attacks, more strokes. I see more skin tears from frailty syndromes and people falling down, more muscle wasting and what we call sarcopenia, which is muscle loss. I see increased cataracts, worsening glaucoma. All of these things I just mentioned are related to hormone decline and lack thereof hormone replacement. So when you look at quality of life markers and the ability to maintain our physical structure, not only physiologically, but biochemically at the cellular level and all the way to our physical structure, that's part of what keeps us well longer. And it doesn't mean we all want to live longer, but sometimes we want to live well longer. And so that whole idea between health span and lifespan. And, I think I had a guy in the office today. He said, you know what? I'd rather live 10 more good years than 30 bad ones. And I thought that speaks volumes, So from that perspective, I'll just tell you that hormones are a vehicle to improve this wellness, longevity, health span piece and help prevent and slow down some of these chronic disease states that really catch up with us all. I mean, we can't stop the chronological clock, but we can slow down the biological clock, and hormones play a role in that. So, all the way to the cellular level, like I was saying. So sometimes that takes time. That's not immediate. It's not a drug effect. It's a hormonal effect. So hormones, all of them, are secreted in a pulsatile fashion. So they're secreted, and then we get a little bit in the blood system, and then it goes into the tissues, and then the levels drop. Then it secretes it. And for some of us, women particularly, our ovaries secrete a certain amount of hormone at a certain time of the cycle. And then when that's over with, they produce very little. So then we have to rely on other organs like our adrenals and our fat tissue, for instance. Our fat is a significant endocrine organ. It secretes 40 different chemicals and hormones. And so, most people just think of it as this fat storage piece of tissue that no one wants. And, what it really is it's an endocrine organ. It secretes hormones that communicate with all kinds of areas in our body. And so, I'm going to jump into this, but I just want to kind of open with that. It's hard to believe I see more hormone deficiency in the ER than I do in our clinic. And one more example is urogenital infections, more UTIs, more life-threatening urosepsis, meaning a urinary tract that turns into a septic infection that we have to aggressively manage. And so, these are people that say, grandma looked good 1 minute, and then the next minute, she couldn't understand what we were saying. She was confused. Blood pressure and heart rate were altered. So, can everyone hear me okay?
I hear something in the background.
Yeah, I'm not sure. Maybe someone's shuffling around there cooking, making up some broccoli or something. So, and there's certain foods that, just speaking of that, since we're around dinner time, there's certain foods that help us manage our hormones better and safer, like broccoli, like sulforaphane in broccoli. So we'll move into this. So you guys, if we get hung up on one topic and it's just us tonight, then we'll roll with it. We'll make a deeper dive into one area, but let me see here. So, this whole idea of anti-aging medicine and lifestyle medicine and wellness medicine, and when I don't always like the name anti-aging medicine, I like the name, lifestyle medicine better. However, these two guys developed, can you see my cursor?
Yes.
Okay, good. These two guys developed this concept of anti-aging medicine from a standpoint of, wait a second, if we really maximize our lifestyle medicine piece, we can really accelerate and prolong life at a healthy level. So these are just this idea of maintaining this physical structure so we don't decline, and this is where hormones plays a role. Okay. So there's a lot of journals now that support this. The Journal of Clinical Endocrinology and Metabolism, the Journal of Obstetrics and Gynecology, the Journal of Urology. These hormone, colleagues of ours are now understanding the significance of the hormones. So this isn't just my ideas here today. I'm pulling these out of peer-reviewed journals. This is an evidence-based talk. And so I can provide you with scores of literature to support what I'm going to say, just so you know that they're not just my ideas. And it doesn't mean they're all agreed upon out there. But this is good stuff. So maximize your cellular health with your focus on anti-aging medicine. That's, cellular health, hormones play a significant role. So I threw these hormones up here as some hormones I would like to at least touch on. And we'll probably take a deeper dive into the sex hormones, but we'll touch on some of the others. And if you guys want to talk a little bit more about some of the others on the page, we can certainly do that. So what I'll tell you is, all of these are significant, but there's 400 hormones in the body that we really could talk about, and signaling molecules that really dictate how we age and what causes stress in our life, what causes dysfunction in our life. So believe it or not, vitamin D's up here because it's actually a pro-hormone. Vitamin D has a cholesterol backbone, just like the rest of the other hormones do. So we actually call it a pro-hormone because structurally it looks very similar. And so is there a hormone up here that somebody wanted that I don't have on the list? Okay.
No.
All right. So, here's the benefits of hormone replacement for a lot of people is, this idea of depression and fatigue. Depression goes up around menopause twofold directly, like within years. Fatigue scores go up dramatically after menopause and after what I call andropause, that's male menopause. There's benefits in terms of it improves cardiovascular health. There's less cognitive decline and improved memory scores with people who bathe their brain in the right hormones. And so if we're going to stop this cognitive decline, then we need to think about which hormones in the literature have been shown to maintain the structure of the brain. And the three main ones that I'll just mention here are testosterone, estrogen, and thyroid. Are three that keep the brain full and healthy. So very interesting. Sexual health, of course, we all think about testosterone, but estrogen plays a role in that as well. So you can take a guy who's gone through prostate cancer and his libido is wiped out and give him low dose estrogen and his libido can come back. So, and he doesn't lose all the other protective effects from cardiovascular collapse without his estrogen. So, metabolic syndrome, people with insulin resistance and metabolic disease tend to have low testosterone levels. So when we increase the testosterone, or those that just have higher testosterone levels, manage their blood sugar metabolism better. People that have a better metabolic rate, in fact, when you look at menopause, your resting metabolic rate drops by about 20%. And when you think about that, that's all day calorie burning. So when you decrease these beneficial hormones and you start to lose more of your lean tissue because you don't have that anabolic support, your actual metabolism slows as well. And that's the same metabolism that burns those horrible lipid cholesterol particles that can cause plaquing of the arteries. That's the ones that can decrease insulin, lower your blood sugar numbers. So all those things. Immune function and decreasing cancer risk. These hormones play a role in decreasing risk. This is where maybe some of the controversy still exists out there, but we'll talk about some of that. Just well-being and quality of life measures. Patients across the board who are on hormone replacement therapy quote higher quality of life measures. Their skin is better, their hair is better, their joints are better, and so their mucosal membranes are better, like we talked about with urinary tract infections and urinary genital atrophy. And now I'm more at risk of, painful intercourse and those types of things. So these are, quality of life measures is so much more. The hormones that we're going to talk about influence serotonin. When you lose estrogen in the postmenopausal years, you lose the ability to convert an amino acid called tryptophan into serotonin. So your serotonin levels actually fall in postmenopausal when your estrogen falls. And then we wonder why our depression scores and our mood and other things are not quite as high as we would have rated them. So similarly with testosterone and dopamine, dopamine is a feel-good hormone. So when those decline, they all can decline together. So insomnia and sleep disorders, I think a lot of you know that I'm a big fan of progesterone, and progesterone certainly can help restore some sleep, or at least help with some sleep on some level. So a lot of benefits. You guys know who this gal is, I'm sure. I think she's gone a little over the edge with hormones, but I'll say this. She looks great. She's aging well. She's beating cancer on hormones. She's done a good job. And she's done a good job of promoting bioidentical hormones, that they're safe and effective and they have dramatic health benefits. One of the things I'll say is inflammation is a big deal. And so hormone optimization is necessary to really optimize and shutting down some of these inflammatory markers that cause disease. When you look at some of the autoimmune drugs, when you look at the cardiovascular therapy, the cancer therapy, we don't want these guys floating around. They promote DNA damage. They promote, cellular degeneration. They promote inflammation. And so hormones really target these inflammatory conditions. So they actually help lower inflammation in the body. So, one of the things that I recently said in a cardiovascular talk is, there's 3 finite responses in our body, and those finite responses govern all chronic disease. And so the first finite response is oxidative stress. With oxidative stress, we will damage DNA, we can damage cells, we can damage cholesterol, we can damage lots of things. The second finite response is inflammation. And without inflammation, we don't have illness and disease or tissue breakdown. Now, I'm talking about chronic inflammation. And then thirdly, immune dysregulation. So I would argue with you from my heart talk recently that cardiac disease is an autoimmune process. Without the immune system turning on to attack the oxidized inflamed cholesterol, we wouldn't lay down new plaque. We have to go through this immune-mediated response to actually harden the arteries. So cancers like this, osteoporosis is like this, all these things are like this. So these are big deals here in terms of really targeting how do we attack those finite responses. Well, hormones, I'm going to propose, are one way to consider that process. What I'll say though is, with any hormone program, we have to titrate to physiologic levels. We have to use the best evidence-based treatments and do it safely for the right person. And you have to marry the two together. You have to put the two together. And some of you know I've said this before. If I'm going to give you testosterone, use it like the cardiology professor told me once. He said, use it like the Porsche. Step on the gas, use it, use your brain, use it in the bedroom, use it in the gym, use it everywhere. You'll maximize your results. If you're circulating that blood, you're circulating the hormones, and they're getting into the tissues more readily. And you're able to use them. So, that goes for estrogen. For some people, if they have growth hormones circulating, it's going to help their growth hormone work effectively for them. All of these things, progesterone, melatonin, thyroid hormone, all of these things work better when we apply the lifestyle pieces. I think you guys know that by now. I'll mention this. There are a lot of chemicals in our environment that disrupt our hormone pathways. And, I know there's somebody on the call right now who represents, and I'll give her I'll give her a few minutes even today to mention something about this. But there are modern chemicals in our diet, and especially for women. The average woman puts 6 to 8 chemicals on her face before she leaves the house. And so the question is, what are those? Are they interfering with our hormones? Do they have lead in them? 95% of red lipstick has lead in it. So when you think about this, when you think about when you go to Starbucks and you get that cup placed on the Starbucks cup, and it's coated with BPA, bisphenol A, or phthalates, or all these other things. And I don't know if you guys have heard of some of these chemicals. I'm assuming you have. Some of the most household cleaners, Scotch Guard, that's sprayed on all of our stuff. our furniture to protect it, our upholstery in our cars and things. So these things disrupt chemicals. And so, the average time it takes for a heavy metal or a toxin to get from your deodorant into your brain and into your bloodstream is about 7 seconds. So when you think of how rapid things get absorbed in polluting our system, think about this. There's a great website called the EWG.org, Environmental Working Group, that will give you some heads up on what are safe cleaning supplies, what are some clean sunscreens and things like that. And I was gonna, if Liz wants to, I'm just gonna let her know. She represents a very good, clean product for cosmetics that looks great, wears great, and very clean. And some of you may already know some other companies out there, but the one Liz represents is one of the best on the market. So just so you guys know that. It's significant though when we talk about these endocrine disruptors that we call some of these xenoestrogens. So is the increase in breast cancer and prostate cancer, does it even matter that is it part of our natural estrogens, or is it part of the estrogens that we're getting from the environment? So these are things to think about, okay? So BPA, phthalates, organochlorines, brominated flame retardants, parabens, all of these things. And we can spend hours just talking about this piece alone, guys. So we're just polluted, and that's part of why our hormones, someone asked me the other day, why are my hormones in such disarray? And, and my counter question was, well, I don't know, how toxic are you? So we need to think about those things, and they do play a role in our hormones. So let's just look at, a basic pyramid of hormone assessment and triage. So I hope you all know this, that the base of the pyramid really needs to be the adrenal glands. And the adrenal glands are these two little walnut-sized glands that sit on top of our kidneys. And these guys produce multiple hormones, little tiny organelles or organs that produce lots of hormones. And so they react to stress in our environment. They react to psychological stress, environmental stresses, chemical stresses, physiologic stresses, psychological stresses. So, I had a guy in today, and we talked about, he had to consolidate businesses. They're getting ready to move their house. They have a child that's having some issues. I mean, lots of big stressors all at the same time. So, if his thyroid isn't functioning perfectly well, maybe his sex hormones aren't either, and they may all be the cause of this adrenal function, this stress response that can disrupt the whole cascade of hormones. So I'm going to try to move through this so we can open it up for more questions. But if you haven't seen this screen before, this is something that we call the sterogenic pathway. So the sterogenic pathway starts with cholesterol up here in the corner. And so all hormones are made from a cholesterol backbone. And this cholesterol backbone is significant. So in the world of statin therapy, aggressive statin therapy, if you went by all the new guidelines, what we've done is we've created, with all these people on statin drugs, we've created a hormone deficiency world. But wait a second, I just said deficiency of hormones causes sarcopenia, osteoporosis, dementia, heart attacks, strokes, cancers, right? All of these significant things. And yet we're causing some of it by aggressively lowering cholesterol levels too much. So vitamin D has a cholesterol backbone, like we talked about. So when you move through this whole pathway, know that it starts here. And going too aggressive with lowering it, we need this for brain health. We need cholesterol in our cell membranes. Every membrane of the cell needs cholesterol built around it. Without it, cells don't function well. The cell signaling doesn't function as well. So all of these things are big deals. And so just so you know, I think that my main point here today, and we can talk about some of these pathways in here, but what I'll tell you is that's a significant piece. And when you look at the new guidelines, the heart guidelines, the cardiac guidelines, and you look at the new regulations, if you're over the age of 65, the new regulations just included 20 more million Americans on statin drugs. So 20 more million instantly. The drug companies were very pleased. And some people will say that 90% of those prescriptions are not necessary. So some of them are, and I'll tell you that. There's a patient that came into my office that said, I want to come off these. And I said, I don't recommend it now. When you have a friable plaque in your carotid artery, you need to stabilize the plaque, and unfortunately statins have been shown to do that temporarily. They also promote calcification of the arteries. That's not always out there, but it actually increases calcification of the arteries. Statin drugs do. So, we'll talk about that another time. I want to do a webinar on cardiovascular health alone and how to set you up to reverse any plaquing you might have. But I'll just say this: we have to be careful about how we go about doing that. So, what we want to do is we want to make sure that we use all the appropriate testing to do this, right? This is a classic thyroid test. Good news, your tests indicate that you're normal, but we see that he's on the very low end of the range because he's not into the abnormal range. His doctor's like, no, everything looks good, right? And this guy's just depleted on the bottom here. So I can't tell you how many people I see that their doctor tells them that hormones are such a bad idea, and now they're on something to sleep, and now they're on a mood stabilizer. And if I told you about mood stabilizers, all the downstream side effects from this, it's unbelievable. So, and we don't have a lab test to test for.
Dr. Woodward,
Yes.
I couldn't hear anything that you said.
Oh, right now you can't? Can you hear me now?
I can now. Sorry
Okay.
about that.
What's the last thing you heard there?
You just started talking about after being on the low end of
Okay.
the cholesterol.
Gotcha. Sorry about that. I feel like I was shouting over here. So, my point of this is we have a lot of doctors in the conventional world that will not prescribe certain hormones because the lab test is normal. And so in the meantime, though, new symptoms show up because of hormone deficiency symptoms, such as mood stabilizers or antidepressants or a sleep aid or an antacid drug. So that's when we then get into this polypharmacy problem. And let me just tell you, antacid medications have so many downstream problems, it's unbelievable. And so, if we can get you off of that, if it's indicated to get you off of that, I would like to. If we can do other things naturally to improve your mood and stabilize mood versus do some of those other things, I would rather do it hormonally than do it with all of these other synthetic chemicals. So just so you're aware, this is very common, right? In today's world, an endocrinologist or even a urologist, based on what the FDA recommends, says if you're testosterone and you're a man and you're at 300, but deficiency says 299, it's not indicated to treat you. So, but what the American College of Endocrinology will state is that hormones should be treated based on symptoms, not levels. That's a clinical statement by the American College of Endocrinology. So we need to treat each person differently and appropriately based on their symptoms. And so this whole level, this range of normal is very interesting. So, everyone's going to have a different level here, and where that stops is different for everybody. So, it might be 650, it might be 850, it might be more. And if we look at your cortisol levels, those are going to be different as well. So our goal is to make sure things are stable and they're within a normal curve range. And if they're not, then we need to address that. So I'm going to move on now to some of the sex hormones, but I just want to see, so far, does anyone have any questions of anything I've said? Is this useful so far? Is it good information?
It's great information. Thank you.
Good.
Yeah.
Good. So let's jump into testosterone. Okay, I'm not sure how this ended up first, but you know, andropause is male menopause. Okay, but testosterone, as we know, is happens to men and women at the same steady decline. It's not like menopause where it can drop suddenly. It's a little bit slower, insidious onset, and then all of a sudden we wonder, why am I fatigued? Why is my libido not where I think it should be? My mood has shifted over the last several years. You know, some of these other things, interestingly, isn't it? It looks just like female menopause: hot flashes, night sweats, feeling overwhelmed, lethargy, decreased energy, even thinning of bones, right? And I don't know if you all have heard me say this before, but after the age of 65, if a woman breaks a bone, the risk of mortality in the first year is 25%. 25% of women won't be around after they break their hip after that age range. And so, I mean, the question always is why? You know, men, a third of them will not be around after that next year. So maintaining your physical structure is so significant. And so I just wanted to comment on that with the osteoporosis piece. And hormones are the only thing that will reverse thinning of bones. So significant piece. So again, we've got loss of, you know, male menopause equals andropause. And so it's similar to female menopause, like I said. It's not as severe, but longer in consequences, right? Long-term consequences. You lose your competitive drive. The thing I ask men that I don't ask women a lot is, do you feel like you're less compelled to engage? And that's something that men respond to well. They're like, yes, that's exactly it. I don't feel compelled to engage. I feel like I'm just moving through life. So stiffness in joints and in the pains and muscles. You know, a lot of men will say, my shoulders feel better. They're not as tight. They don't ache as much. My hips possibly. And so decreased level of fitness in your workouts. If you don't have anabolic support from testosterone, you will not recover and repair well. There's an increase in heart attacks, strokes, and heart malfunction with cardiac disease or with testosterone deficiency. So there are two studies. I'll just address this right off the bat. There were two studies that were published that said, no, there's an adverse effect for cardiac illness. And they looked at a VA study in this. And I'll just tell you that study has been rejected by almost every peer-reviewed academic college that exists. And the study's been picked apart for poor study design. There was a petition by 63 agencies and to have that article removed from JAMA, the Journal of American Medical Association. JAMA has never retracted a study in their 90-year history, and nor did they retract that study. So it's in front of us. We have to address it. And I'll just tell you this, that in the balance of things, the study didn't hold up to its criticism. And so there's about 300 other studies that show benefit in terms of reduction of cardiac disease and improved cardiac function. So testosterone dramatically impacts these things. In fact, men who had higher testosterone finished cardiac rehab faster and more effectively than men with lower testosterone levels. So, and that should really apply to women as well, but the study included men. Decreased memory, intelligence, cognitive processing speeds, all lower with lower testosterone levels. So, and again, sarcopenia, that's thinning of the muscles. How many of you see the wife helping the little old guy across the street now, or helping him into the car, carrying him, holding his cane? So sarcopenia, muscle loss, bone loss, anemia. When testosterone's low and you give a man testosterone, you improve his anemia scores. He has more oxygen carrying capacity in his blood now with more red blood cells. He's less fatigued. His mood lifts. So, you know, in a nursing home, you know what they give men who aren't eating as much because they're depressed? They give them progesterone. They give them Megace, it's called. Megace is a synthetic progesterone. It lowers their testosterone even more, and it doesn't work well. You know what works well? Testosterone. Give the 90-year-old guy a shot every 2 weeks, and he's going to feel better. And all of these things improve. So frailty syndrome is probably the #1 cause of disability in this country. from osteoporosis and osteoarthritis. So again, testosterone declines all the way. It starts in the 30s for a lot of people, but declines all the way. So, there's a 50% decrease in bioavailable testosterone between the years of 20 and 75. So, and it gets lower every year. So everyone has a different decline there, though. So it's different for everybody. Testosterone replacement therapy and erectile dysfunction. Some men who have to use some dilators to help them engage, their response to Viagra or Cialis or any of those improve because they actually increase their nitric oxide receptors, not only in that area of the body, but also in the heart and the brain and other areas that dilate arteries. So nitric oxide we need everywhere in the body, including in that region. So it can take a little while, though, because we need to cellularly do some adaptations with things. So I'm going to skip through some of these studies for just sake of time, but just so you know, low testosterone predicts cardiovascular disease. Look, 11,000 men in this study between the ages of 40 and 79. It predicts cancer and cardiac disease. This study showed a 41 decrease in chance of dying with men who had a testosterone greater than 560 compared to those at 350. There are some correlation studies now with women as well with the testosterone showing less breast cancer, less heart disease, less osteoporosis with testosterone as well. So, for every 173 points of increase, the chance of dying went down 14%. And there's all these collateral benefits, right? There's lots of benefits here. So, and this study was not giving them endogenous testosterone. Giving them exogenous testosterone that they took. This is a study just comparing men with low, comparing with men with higher testosterone. So again, more mortality. I'm just going to say that, men treated with testosterone had less prostate cancer. Mortality was a whole difference by 10% in this study. So it just goes on and on and on. So there's two metabolites that testosterone produces. Estrogen. You can produce a little bit of estrogen depending on how much testosterone you take. And what depends on how much your testosterone gets converted to estrogen are some of those endocrine disruptors that we talked about earlier. Some of those act as aromatase and convert all your testosterone over to estrogen. And so we have to be careful from a toxicologic standpoint, as well as if we don't want to convert the testosterone to estrogen, we can block that pathway. Now, if you're taking very little testosterone, the conversion is usually very, very tiny. It's so tiny that your fat cells in your body produce more estrogen than the testosterone that you would be taking. So it's negligible. No study has shown, again, remember, testosterone has been shown to decrease breast cancer in women, not increase it. Dihydrotestosterone is another metabolic byproduct. So again, cognitive function improved. It increases blood flow to the brain because remember, it dilates the arteries and the veins. So we get more blood flow to those areas of the brain that are struggling. It prevents beta amyloid proteins that get deposited in brain. That's what causes Alzheimer's disease. So when you look at Dale Bredesen's stuff on cognitive decline, he's going to tell you that testosterone is one of the key factors in preserving and improving cognitive function. So if any of you out there have an ApoE4 genotype, this is important to know.
What's the TRT again stand for?
Oh, I'm sorry, testosterone replacement therapy.
Oh, okay.
So, so some significant studies. So I just said, you know what, we can talk study after study after study for the last 70 to 80 years on testosterone therapy. There is an enormous amount of data on this in terms of its cardiovascular effects. No study has shown that testosterone causes prostate enlargement or cancer, not one study. And so this was an old meta-analysis in the New England Journal of Medicine. So, and again, prostate cancer, this is another one comparing men with treated and not treated. No associations between the risk of prostate cancer and testosterone therapy. So, for some of you ladies on the line, nice to know about either husbands or friends or family members that if this is a concern of theirs. There are no studies to date. In fact, Abraham Morgentaler is the head urologist at Harvard who's done more research on prostate cancer and testosterone than anyone on the planet. He did a resolution evaluation 2 years ago, and he came up with 10 resolutions, and one of them was there still is no evidence for testosterone relations to prostate cancer in terms of causing it. So we can talk about some details if that comes up in a minute. So I'm happy to answer those questions later. But just so you know, it's not been shown to cause it. And even men who have it, it doesn't increase it. So we can, there's some details around that we can discuss. There are some side effects. We've got one guy on the line. So unless anyone else has a question about this, I'm going to move forward with this. Let's get into the female hormones here. So again, if you look at the top 10 symptoms of menopause, it's very similar, right, to the andropause. So very similar stuff. And so, the hot flashes, the mood swings, I'm going to tell you right now, hot flashes are associated with increased cardiovascular poor outcomes. So we know that your arteries are not functioning well when you're having hot flashes. So sleeplessness, all of these things can really impact life and quality of life. So when we look at the female hormones, I'll just say this. I do believe there should be a balance between estrogen and progesterone. And we can measure that balance. There are some markers that we could look at your levels and look at them. Now, I'm not as aggressive as some of the integrative or even conventional hormone docs out there in terms of estrogen use. But I am with progesterone and I am with testosterone. So I'll just tell you that you will always have a favorable balance with me because I'm much more aggressive with progesterone than estrogen. I like to give enough estrogen to get the effect and stop. So what I'll tell you is there just needs to be a balance between the two. And we can measure that in the serum, or we can measure that in the saliva, or even the urine. I think the best reliable measures are still serum because that's where most of the data exists. So just so you're aware of that. And we could do your balance if you want next time you're in. We can do the ratios and I can show you which ratio is the best, okay? So we'll show you, are you in an estrogen dominant phase even though you're on hormones? Are you in a favorable phase? Because when you look at the data out there, I'll just tell you, I don't give any woman in this clinic estrogen without progesterone. And so progesterone, no matter what you were told by your OB-GYN, is critical to balance some of these things out. And so I know that a lot of people have been told, well, I had my hysterectomy and they told me I didn't need it now because it only protects against uterine cancer. Well, that's not true. It protects against breast cancer, and it helps your cholesterol panel, and it helps with cognitive decline, and it's an anabolic bone hormone. And, there's just so many more things it helps with. So it and estrogen also help maintain better healthy hair. It helps with sleep. So, as you can tell, we can go on and on, but the concept is there is a good balance, and we want to make sure you have plenty of progesterone around because it influences how estrogen behaves in tissue. And we want estrogen to behave well in tissue, which is why there's less breast cancer incidence in women who are on estrogen and progesterone than women on no hormones at all. So I'll say that one more time because some people haven't heard that yet. There is less breast cancer in the literature, and this is a recent study, and there's more than one. And the biggest hormone study to date on women, 55,000 women in this study versus 16,000 in the Women's Health Initiative, showed that there's less breast cancer with estrogen and progesterone than no hormones at all. So bioidentical estrogen and progesterone increase, so these are the counter arguments. Does this increase the risk of cardiac disease and breast cancer? What do we look at the clinical picture when we dose, or do we look at the lab tests? why not use bioidentical oral estrogen? And is that okay to use? Or should we only stick with transdermal creams and patches? These are common questions that come up. And why does she need the progesterone after the hysterectomy? So what you should know is there's 3 different estrogens. And there's estriol, which is the main one during pregnancy. This is the one that they give a lot of women who have some like vaginal dryness or vaginal atrophy. And so this one really helps a lot locally. It's about 80 times weaker than estradiol. And estradiol is the main estrogen. So this is the one that's cardioprotective. This is the one that keeps the brain healthy and active. This is the one that decreases our risk of heart attacks and strokes in men and women. So the estrone is the one we don't like. This is the one that can produce abnormal estrogen metabolites that can cause unwanted signaling to tissue. So we don't like this guy, which is why we never give estrone to people. We only replace it with either estradiol, estriol, or a combination of both. And so I like them both, but estradiol is just, it does a much better job in terms of getting into the tissue and making a better job of it. So the big controversy came up with women's hormones with this study. This study was called the Women's Health Initiative. And this one said, hey, wait a second. What the study planned to show is that hormones were beneficial, that they were going to decrease the risk of heart attack and stroke and breast cancer and blood clots. And so what they said is, hold on a second. We're seeing too much harm here. Let's stop the study. So they stopped the study because they felt there was clear harm. And then this Women's Health Initiative was published in 2002 in JAMA, but it was planned to go until 2005. So over 16,000 women, the average age was 63. And so when you look at this study, the one thing I'll tell you right off the bat is there was a fracture reduction from osteoporosis and there was a decrease in colon cancer. That continues with bioidentical hormones. What I'm going to tell you is this study was not about bioidentical hormones. This study was about synthetic medroxyprogesterone, which is a synthetic progestin, not a progesterone, and Premarin, which has about 10 different types of estrogen in it, predominantly 3. Estrone, the one that I said creates toxic metabolites, equilin and equilin. And so those are 2 horsemeal estrogens that they included, and that's all they studied in this study. They used to call it Prempro. So Prempro, what the study is correct on is that you should never use those hormones, which we never do, and nor would I. What the general public does with this is they put all the hormones into one bucket and says, well, all estrogens are the same and all progestins and progesterones are the same. Well, that couldn't be further from the truth. And that's been gleamed out in a lot of the literature now. So now even a lot of the OB-GYNs that I know are prescribing hormones again. They let this smoke clear. They defined the study. They found out the flaws in it. And they said, okay. But there's a lot of practitioners that still believe that all hormones are created equal. So the Women's Health Report talked about biosimilar hormones, the synthetic hormones. No studies have ever associated bioidentical hormone replacement with increased risk of cancer. None to date, guys. So, and it has been studied, trust me. So here's a big study. Fournier followed 80,000 women for 8 years, looking at hormone replacement users. Now, this one looked at estrogen used alone. This one showed a small increase in risk of breast cancer. What I'll tell you is the Women's Health Initiative that we just looked at followed these women out who stayed on the Premarin and found a reduction in breast cancer, even though they weren't on progesterone. It was a 17-year armed study on that one. So this study, it's a pretty big, well-powered study, well-known, Fournier, showed a small increase in estrogen in breast cancer risk. The synthetic progestins and the estrogen increased the risk much more so. But when you added bioidentical progesterone to the estrogen, limited any increased risk, and there was a reduction in breast cancer. So, following that study, a much more well-powered study, so you see why I will never give estrogen without progesterone. And there's 3 other huge studies like this, but multiple other small studies, including the Women's Health Initiative. So those are good things to do. That's kind of the elephant in the room, really. I think that's what scares most women is breast cancer. And so then we even talk about, well, what are the studies showing following breast cancer? What's the safety of that? And we can break that down for those that want to later. But again, benefits of progesterone on the cardiovascular system: it decreases LDL, it decreases Lp(a), homocysteine, better blood pressure control, less platelets sticking together or aggregation so things don't clot as easily. It relaxes the coronary arteries. This is right out of the OB-GYN residency manual, endocrinology and fertility. Again, benefits of progesterone, all of these things we kind of talked about. Fibrocystic disease, uterine fibroids. I love this one again, which is why it's highlighted, protects against breast cancer. So what happens if I had a hysterectomy? Should I not use it to protect my breast? Should I not use it to sleep better? Should I not use it for its cardiovascular benefits and its decreased blood clotting problems? So you can see there's tons of benefits here and gleaned out in the literature. This is one of the things that I'll just mention briefly. And you can see estriol, the safe estrogen. Even someone who's had breast cancer, estriol is a safe hormone. So any oncologist I've ever asked and said, would you mind if I use some estrace or estriol vaginally for this patient? They're usually fine with it, because you can see this is an end stop of the metabolites of estrogen. It doesn't go anywhere else. It doesn't go into the carcinogenic pathways, but you see estrone does, right? So the 4-hydroxyestrone and the 16-alpha hydroxyestrone, these are more of the carcinogenic metabolites that we don't want. The problem is estradiol can convert over a little bit to estrone, and we can make it into these metabolites. So it doesn't do it easily, but there's that potential. And so estriol is the safest, but it's the weakest, and it doesn't protect our bones or our cardiovascular health. It has a little bit of effect on the bones, excuse me. So what we do is we promote the pathways to go down this way, the 2-hydroxyestradiol, and then it gets methylated, right? You guys have heard about the MTHFR gene and the methylation pathways that we talked about. This is what we mean. It makes the estrogen safe estrogen metabolites. It's protective. It doesn't proliferate the tissue and cause problems. So when we do this, for some people, we will look at their estrogen pathways. If they have these pathways, we want you to be on something called DIM or IC3. And DIM and IC3 we have in the office. It's a nutrient supplement that promotes the conversion of estradiol into the safe metabolites. So that is one of the things that we try to do when we're trying to manage estrogen better. So let me move through this, finish this up here, and then we'll open it up for really specific questions. But thyroid, if someone wants me to talk about it, I talk about thyroid a lot. But one of the things you will hear me say is that thyroid is key for metabolic health. It's key for brain health. It's key to reduce your cardiovascular risk, diabetic risks, and a lot of times it just helps us feel better. So free T3 is really the best clue. So that's why I focus on T3 when I'm looking if someone's fatigued or depressed. Thyroid hormone outperformed all antidepressants 2 years ago at the American Academy of Psychiatry. So, it's a key hormone. It can help with weight loss. Fat loss, it protects against arrhythmias. So a lot of people are like, oh, I don't want to take the dreaded thyroid. It can cause arrhythmias. Well, if you're low thyroid, it can cause arrhythmias. If you're too high, it can cause arrhythmias. So we have to monitor that. And so I think T3 is the big actor, and really, on all of you, we check reverse T3. So I can get into that a little bit more as well, but something to look at. And I think that T3 is where we should focus our eyes, and then everything else should come secondary. So, People tend to feel better when we replace both T4 and T3 instead of just Synthroid or Synthroid and levothyroxine is T4. Cytomel or a compounded T3 is the other. And Armour, NP Thyroid, Nature Thyroid has both of them in it. The studies show that people replace both, they feel better, they rate their quality of life better. So, but there's factors that can decrease the conversion of T4 to T3 and cause lots of problems. Stress, cyclical dieting, zinc, selenium deficiencies, drugs. So all kinds of things can get in our way. Those endocrine disruptors we talked about. And so I'll just tell you that when I optimize someone's thyroid, I think between 0.1 and 1.0 tends to be more optimal based on how people feel. And free T3 tends to be better when we get closer to 4.3. So you can look at your labs and kind of see where you're at with that and see if you still have room to feel better. So I kind of said all this already, but T3 helps with weight loss, cholesterol, brain health. This one gets people's attention. A TSH, if you drop a TSH from 4 to 0.4, it's 12 pounds. So it can make a difference when you have that big of a shift. Now going from 1.1 to 0.5, may have an impact. So again, free T3, reverse T3 should always be checked, especially in cardiac patients. So when you look at some people, when they maintain cardiac function better, free T3 is an independent factor on how well the heart contracts and functions, how well its ejection fraction is. So especially in congestive heart failure patients. You know what? I don't know a single cardiologist that measures it other than the integrative cardiologist on the south side of Charlotte. So adrenal testing, adrenal fatigue, that is a huge monster to tackle. I'm just going to say we do like to measure it with serum cortisol, or excuse me, saliva or urine testing. How do we treat it? That's a big can of worms. Reducing the stress in your life. We do have some adaptogens. And adrenal function, like we talked about, is the base of the pyramid. So that really can impact the other hormones if it's dysregulated. So as you can see, if there's cortisol can inhibit thyroid function at multiple levels. It can impact hormones coming out of the brain and the hypothalamus and pituitary. If it's abnormal, the adrenal glands, it can affect all of these pathways all over the body. And so, and the underlying piece of this is stress, of course, metabolic, physiologic, environmental, psychologic stress. So all of those can affect these adrenal glands. So when cortisol is increased, it competes with progesterone, thyroid, estradiol. It can cause increased cortisol can actually cause atrophy of the hippocampus of the brain. It can actually cause memory deficits by causing atrophy of that area of the brain, mimicking almost a cognitive decline scenario. It acts like a prednisone or taking steroids. It decreases immune function. It can cause fatigue and for frailty. It can increase blood pressure, lipid panels. It can cause low energy. So, and very low cortisol can do the same. So another adrenal hormone is DHEA, and here you'll see women and men, even though they spike differently, they decline around the same rate. DHEA is kind of a forgotten hormone sometimes. It's very effective. It can help with libido and motivation and mood. It can help with the immune system, and it can even help with insulin sensitivity. There's been a couple small studies that would suggest it can help with triglyceride lowering. And so I gave this to a guy once, and a couple weeks later he said, "Hey, what was that you gave me?" That's the only thing I gave him. I gave him a multivitamin, DHEA. And he said, "I just feel better." And so it can have that impact. So I like to put your DHEA typically in the upper third of the range, of the lab range. And that may make an impact. So, and it's an anabolic hormone. So it's much less anabolic than testosterone. So, there's weight loss hormones, and these are the main ones that we consider. Optimizing thyroid can help with weight management. Testosterone can help with weight management. Estrogen, low estrogen shows worse body composition. So some estrogen better than none. Too much estrogen, however, can also add weight on. So there is a sweet spot for estrogen. But women who have none or little or no replacement, they lose the body composition effects from that. And growth hormone. Growth hormone is a contentious area today, but there's ways to increase it in your body naturally. The first place to do it is get better sleep and eat better, and strength train. The same thing with testosterone. Starting with the lifestyle pieces first, making sure there's enough zinc to support testosterone. Those are some things that we consider. But we also have peptide therapy now, and peptides can be injected under the skin Monday through Friday, and they can increase your own growth hormone production. And I'm happy to talk about any of those options with you. We have about 3 different peptides that can increase growth hormone. It takes time. It takes months. But the therapies on the peptides are just fascinating. I'll just tell you right now, I just ordered some for myself. And it's a natural peptide that naturally occurs in the body. I want to see what it'll do. I want to try it. So those are options available in this clinic as well, because growth hormone helps brain health, heart health, bone health, all of those other things. I really didn't put a lot of emphasis on growth hormone today, but let me tell you, it is the anti-aging hormone. Talk about making your skin better and memory, and it just does a nice job. It really helps. It's a lipolytic hormone, so it really helps burn fat centrally. Now that one can take a while as well, so just so you're aware of that. Leptin is the satiety hormone. This one gets secreted, from the fat tissue, and it goes up to the brain, and it says, "Hey, we're full." Well, guess what? Insulin and other things can block the leptin from getting to the brain to say we're full. So we have to manage other hormones, not such as insulin, not just the satiety hormones and the fat burning hormones. So hormones are cancer protective. They're cardiovascular protective. We have less liver, colon, stomach cancers when we optimize hormones. We have better immune function. When you look at these finite theories of aging, such as oxidative stress and the free radical damage theory, inflammation, and immune modulation, hormones support all of those things. And food supports hormones. So we want to eat well. We don't want to stimulate the wrong hormones that will interfere with ours. So, basically in summary, hormones are just an overall part of the functional approach. Lifestyle medicine is by far the foundation. There's other things we can do with nutritional support and other things, but there's evidence that is so strong for bioidentical hormones right now. It's hard for me not to invite my family members to be part of having that part of their lives. And so if there's dysfunctions that we see with hormone deficiencies, we can treat them and they can make a big impact on us. So I'm going to just open it up for some questions now that I didn't get to, because as you know, there's so many hormones we left out. I didn't even touch on melatonin and some of these others. So what kind of questions might you guys have, if any? Any questions, guys? Was I that good? Was I that thorough? I have an interest in this, and yet I'm very cautious. And so I want you to know this too. When that study came out in JAMA in 2014, it was January 2014, I was actually at a conference, and I was looking through my phone, and I saw the Medscape blurb come up about this study that was released. I called all of my patients on testosterone at that time that said there might be a cardiovascular problem with this. I said, hold on a second. Before you hear this, and this is on the news, let me look into this before we make any rash decisions and judgments on this. And so my eye is very watchful of the new literature. I'll tell you that. I go get updates all the time. I'm part of colleges and collaborative groups where we update each other all the time with the current most trends in terms of evidence-based medicine. So I will be that watchdog as best I can for you. And I have people that are my watchdogs that let me know about things. That's why I belong and spend a ridiculous amount of money to have memberships to places. So they can sift down the literature and present it to me appropriately. So, but some very interesting stuff in the hormone world, and I think most of us are interested in having a better quality of life. So I think hormones can be part of that at some level, and we can define that on an individual, personal level. As Florence Comite from Yale says, it's an N of one. Your study with each of your patients is individual. It's an N of one. And so I like that mentality, and we'll apply the best evidence for you to do that. And if you are all interested, we can get together and talk more about hormones and break it down more specifically into certain types. We can talk about chronic fatigue syndrome and hormone therapy, more specifically about adrenals. Corrine has a class on inflammations, which is great, that I highly recommend you all do. Karen has a class on gut health, and I believe she's going to do that next month. So there's a lot of good stuff coming up, and I recommend you do those. I'm going to do the behaviors class again, and I'm actually going to put together a little webinar that I'm going to record and just send out to you guys. It's on cardiovascular health, with all the latest, greatest literature on that. So
I do have a question on the female hormones, where in the study about the breast effect on breast cancer.
Yeah.
What was versus the E3 versus the E2? Is there any effect? Do they say it's safe to do E3, but they're not sure about E2, or what is the?
Yeah. So what I'll tell you is that there's been a recent study, and this study was published, I think it was 2015, and this was the study that had 55,000 patients in it, much bigger than the Women's Health Initiative. Not quite as big as the Fournier study, but what the most conservative people will tell you, and these are people I trust too, will say, if you had an estrogen-sensitive tumor, just stay away from estradiol, period. What the literature shows for postmenopausal breast cancer patients, post-breast cancer patients that had hormone-sensitive tumors, they will say that after 2 years, the studies still show that there's less recurrence with women on hormones than women on none, which is interesting. When I saw that, I thought, I need to talk to some people about this before I buy into this piece. But so what I'll tell you from my perspective is, I wouldn't give a woman with my comfort level right now, unless their oncologist endorsed it and the woman really wanted it. If they wanted estradiol with a hormone-sensitive tumor. Now, if it's been 7+ years, I would consider it, still with the consent of the oncologist. And so that being said, estradiol, then I would consider if you're 7 years out, even 10 years out. So the chance of recurrence is very, very low. And so my concern, though, of course, is we've all heard stories of reactivation of some of these cancers. And so what we do know is estriol would be safe at any stage in the game. In fact, they give estriol to women with estrogen-sensitive tumors, and it helps slow down the progression. And so just so you're aware, there's an alpha and beta receptor site. And it's the alpha estrogen receptor that is the proliferative abnormal one. And let me see here. So the alpha subunit is more of the proliferative, and the active estrogens, these metabolites seem to be responsible for activating that alpha receptor. Estriol almost only hits the beta receptor, and it preferentially influences the beta receptor, which tends to be protective and anti-proliferative. So these are estrogens, but they hit the beta receptor sites typically. And as you can see, estriol, there's no downstream metabolites from it. So it's considered a safe and appropriate use for someone who had estrogen sensitive tumors. So it's a very common thing that someone would be okay with estriol. But estradiol, as you can see, can get over to the estrone pathway and make its way into these guys, depending on how much estradiol you took. So one of the things that I've done with women who have had breast cancer that really, they're really concerned about their osteoporosis and cardiovascular health, because they know that the cardiovascular and other pieces has a 10 times risk of taking their life above the breast cancer coming back. Is that what I will do is I will make a cream, and I will make 80% estriol and 20% estradiol. So we make it a very weak estrogen combination, predominantly estriol. And for some women, we've only done estriol. And so, we kind of match it to their symptoms. But so yeah, good question. But the good news is this is why I showed this slide, is because it shows this as an end stage metabolite. Estriol is the end stop, so it's not going to go anywhere else. And it hits the beta receptor, which is the protective receptor. They're doing therapy now that are looking at other pathways that try to stimulate that pathway. So most of the estrogens get shuttled down these ways, and the estriol. Did that answer your question?
Yeah, just one extra question. Then, is there benefit to just taking estriol along with progesterone?
Oh yeah, for sure. Particularly they weren't sure, because it's so much weaker. They weren't sure how much effect it was going to have systemically, because since it's 80 times weaker, but it has had an impact on the bone health. And so, and we know it works wonderfully vaginally. So vaginally, it has lots of great local effects, improvements of vaginal thickness, vaginal sensitivity again. And if we put that, sometimes what we do is we mix DHEA and estriol together. So you get a little combination of both. And the DHEA is great for libido, but the DHEA is also great for vaginal health and thickness of that mucosa. And so sometimes we'll do that. And sometimes we put that in a hyaluronic acid base, so it really absorbs well and causes a nice vaginal mucosa there as well. But I'm focusing on the local aspects, but there is some systemic effects. Not as much in the cardiovascular literature have they shown that with estriol necessarily. But they've been focusing on some of these pathways, as you can see, the 3,4-A and the 1B1 and the 1A1, because what we want to do is we want to know that, hey, how do we activate the 1A1 pathways, either with food or other things? And I'm going to move this here. And how do we shuttle things over to estriol more effectively? Well, even in here, it shows you what activates these pathways. Remember how I said DIM and IC3-carbinol and sulforaphane with broccoli, cruciferous vegetables? It activates the 1A1 pathways. So what we eat and how we exercise makes a difference by which estrogen pathway is activated. These polycyclic aromatic hydrocarbons, these PCBs in our environment, they're problematic. So, and so what shuttles this down, what slows this down are hops, bioflavonoids. Bioflavonoids are in fruits and vegetables, grapefruit. These things slow down this pathway. Sugars, fats, omega-6s, oral contraceptives, which are synthetic progestins, cimetidine, right? These things actually slow down this pathway. So hypothyroidism would increase this pathway, right? Pesticide exposure, smoking, caffeine, various medications. But we go to these things and we do want to slow down this pathway. We only want the 2-hydroxy and the 2-methyl estrogens. We want those to be metabolized well. There's also some research going on around the 17-beta pathway. How do we shuttle more E1 into E2 so it doesn't go down over here, so we don't get access to these bad ones? So there's things that, this sterogenic pathway shows in terms of how are these estrogen metabolites being handled, and what are some of the lifestyle factors that we can do to keep hormones safe And so anyway, that went beyond what you asked, but I just thought this diagram, and I can provide any of you with this diagram whenever you want. Just kind of interesting how it shows all the different things that can impact these enzyme pathways and how things are metabolized and how we can influence that.
Okay.
Did that answer your question?
Yeah, that's great. Thank you.
Oh, you're welcome. So now I got off into this slow thing. One of my jokes used to be, okay, women, when do you want your husband's testosterone to stop? You know, and they're like, stop. So, you know, remember that study we talked about with even men of 564 versus 350, 41% mortality, all-cause mortality, cancer, strokes, heart attacks. So, you know, they just haven't done some of that data on women, and I think some of that's coming. So there's a lot of good data here, a lot of good stuff. I focused on the female hormones and the men's hormones a little bit more. But, you know, I think you can see there really is good data for this. And there's some really interesting studies out there that are ongoing currently that are just very fascinating. I didn't even get into heavy metals, but heavy metals are another big problem out there that are really causing problems with cardiovascular disease and starting to be well recognized. So they're interfering with hormones that may help us lower our cardiac risk. So interesting. Yeah, anyone else have a concern or question?
I have one little question. It doesn't have anything really to do with the hormones. Would we be able to revisit this recording?
Yes, this is going to be recorded. This is being recorded right now, and I can send it back to you. Yeah.
Fantastic. My other question is, on a menopausal woman, would it be beneficial to either do peptides, DHEA, with testosterone and progesterone?
My favorite, if you were to ask me to triage one to the top, I'd need to know symptoms more specifically. There's been a few times where we started testosterone first. Mm-hmm. But, you know, if someone came to me and they said, look, I'm having a hard time sleeping and I have some unexplained anxiety and I want to protect my bones and work on some of the other pieces that progesterone provides for me, like some decreasing my breast cancer risk or uterine cancer risk, I'd say progesterone should be your starting point. And I do like to start one hormone at a time, typically, and just to see how it's tolerated. And we might have to use a cream versus an oral capsule. I like the oral capsule better because it seems to be more evidence showing tissue penetration with it. But there has been some more evidence showing that there is some tissue penetration with some creams. It just depends on what dose. And because if we're going to get protection from a cancer standpoint, we need to know that it's getting into the tissues and supporting that purpose. Now, if you said one of my pieces that I'm looking to gain from the testosterone that I would triage to the top is the body composition, the cognitive help, especially if you have the ApoE genotype like I have, which would put you at increased risk of Alzheimer's and cardiovascular disease, and my libido is really in the tank and it needs some help, then I would say, well, maybe we start with testosterone. We can add progesterone, you know, in a month or two once we establish that you're tolerating this okay. So I think either one, with the idea that I'm going to recommend both. I don't see any downsides of progesterone. Testosterone can be temperamental with people. So most people notice benefit, but it's not the same for everybody. And so some people do better with pellet therapy. Some people do better with creams or troches. There is no oral testosterone therapy. So, and then we just kind of personalize it to you. I'm a fan of estrogen because it's the big one that helps protect against cardiovascular health. At the last hormone conference I was at, a cardiothoracic surgeon stood up and looked at everyone and said, I just want you to know the only thing that reverses coronary artery disease in its effect is estradiol, which I thought was pretty interesting for a cardiothoracic surgeon in Palm Springs to say that. The talk wasn't in Palm Springs, but he was. And he, it's a well-known hospital in Palm Springs that's escaping me right now, but you have to be pretty well known to take care of some of the folks in Palm Springs as a very known surgeon. And he strongly believes that estradiol has a big effect on the cardiovascular system. So, that standpoint of things, we would want to evaluate all the hormones and maybe put them all on eventually, because they all have their own sets of benefits and risks, or side effects, I should say. Hopefully most of the side effects are all the good ones.
Well, that was my sort of my question, is if you're menopause, you're already through post and all that other stuff, and you're on what was I saying, testosterone and progesterone, why wouldn't you put somebody on estradiol too?
I would.
Would you?
Yeah, and sometimes it's just we started there and we haven't gotten to the discussion of estrogen yet, and like I said in the beginning, I'm a little bit more free with the progesterone and testosterone. Even though there's been some great big studies lately with estrogen, I like estrogen. I think it's great. And now that we have studies that show that there's actually less incidence of developing breast cancer, it doesn't mean you don't have any risk, right?
Right.
So just like with men with testosterone, it doesn't mean they can't get prostate cancer. It just means that it wasn't from the testosterone. And so it doesn't cause it. It doesn't cause the tissue to become abnormal. And so that's where some of the disagreement out there or the concern is. But no, I think I think estrogen can be a great thing. Yeah, for sure. In fact, women that do our pellets, I just add the estrogen in for free if they want it, because I just use such low dose. But it can make an impact.
Okay. I appreciate it. Thank you.
Yeah, you bet. I was gonna, if Liz, is Liz Fackelman on? Liz? No. Okay. She was gonna, I was gonna have her introduce the cosmetic line to you, but I can have her put something together and I can send it out to you. We also had another beauty counter event here recently about safe, clean cosmetics that don't have the phthalates and parabens and BPAs and some of these other chemicals that can be endocrine disruptors in them. So I think that focusing on wellness from a broad spectrum, what we eat, how we exercise, what toxins we're exposed to, plays a big role there. So just want to overemphasize that I'm not just looking to put people on hormones. I want people to surround themselves in the right cocktail and use the hormones with exercise and their brain. And I wanted to make them their life improved by it. So
That would be great to know about the cosmetics.
you bet. I'll get some more information on it. She did send some over to me recently, and I'll see if she has something on a email that I can distribute.
Fantastic. Thank you.
Yeah. Well, you guys, I appreciate you chiming in tonight on your night, and I hope it was worth your time. And looking forward to, if you guys have some ideas about other types of talks that of interest you, that maybe I already have done, that we just haven't pulled out in a long time, and I need to update, I'd be happy to do that. And so if you have some strong interest in a certain area, let us know. That's something I wouldn't mind doing. Especially if we can get a group of folks to come on the call.
Absolutely. Thank you, John.
You're welcome.
Okay, yeah, thank you so much.
You're welcome. Have a great night, everybody.
You too. Thank you.
Bye-bye.
Bye-bye.
Thanks. Bye-bye.
Bye-bye.
Interesting.